Good evening, everybody. Welcome to this second webinar on pediatric tracheostomy. If it's all good, you can hear us now, and we have started. I will start to share my screen. There we go. And start our presentation. Okay, so once again, welcome. Yes, I think we have some attendees coming in right now. So once again, welcome to this second part of this webinar on pediatric tracheostomy. Let me start off by introducing you to our distinguished panel. First from Lisbon, Portugal is Joanna, UK. Georgios Patsiamos from Stockholm, Sweden. Questions, so there are like 12 questions and everybody will cover his or her own topic and read out the questions. You'll get a chance to answer them, and then afterwards we will be covering the answers and give you some more additional information. For the attendees, if you still have any questions that you want answers there, you can ask your questions in the questions box. Just put them in there and send it, and we will cover the questions at the end of the session. I think that will be wise. So I think the attendees, almost all attendees are here now. So I think what would be wise is just to start with the first question, and that was from Joanna.
So the first three questions are on tracheostomy home care and multidisciplinary team assembling. So the first question is concerning tracheostomy home care, which of the following are correct? Remembering that more than one possible answer is possible. So option A, tracheostomized children cannot attend school due to constant need of suctioning. Option B, children should have an emergency kit with them when they are outdoors. Option C, caretakers need to have basic cardiopulmonary resuscitation notions. Option D, apnea monitoring is mandatory at home at all times. And option E, caretakers education should start after discharge by the outpatient community team. So we'll give you some time to answer and then we'll comment on your answers.
So you see the poll now and you can give your answers. I can see that some of the answers are coming in. Remember that more than one answer is possible. Still need some votes. Okay, so this is all the answers that I think we are getting. Joanna, do you see the answers now?
I cannot see the answers, no. I can only see the poll.
Okay, I think now.
Not yet. Oh yes, now I can see it.
This is it. Yeah, there you go.
So 94% of the attendees said that children should have an emergency kit when outdoors, and that's completely correct. They should have not an emergency kit not only when they are outdoors, but also when they are indoors. They should have an emergency kit with a same size and a smaller size cannula, cleaning material, suctioning material, and information about the tracheostomy. And so all of that should be with a child at all times. And so option B is correct, that's true. So option C, caretakers need to have basic CPR notions. That is also correct. Before discharge, parents should be able to realize emergency red flags on their children's tracheostomies. And so if needed, they should have basic CPR notions. So that is also correct. Considering apnea monitoring, so that is a tricky one. Some countries and some places, some centers do have apnea monitoring for every discharged tracheostomized child. That is not actually true for a lot of countries, not on my country. For example, children only have apnea monitoring at home once they are doing the cannulation protocol. And so it is not mandatory to have apnea monitoring at home to have a child with a tracheostomy discharged. So option D would be incorrect. Considering option E, caretaker's education should start way before discharge. Ideally, it should start even before the procedure is done, before the tracheostomy is done. And so before discharge, parents should be left alone in the ward, and they should be able to perform their duties with the tracheostomy day and night, almost by themselves, with a lot of help from the multidisciplinary team to help them educate them and monitor those steps. So option E is incorrect. It should start before discharge. Considering option A, children should go to school if they can go to school. So one of the goals of discharging them is actually to have them have a normal life as possible. So if they can go to school, they should go to school, but school personnel should be able to deal with suctioning or cleaning the tracheostomy if necessary. So option A is incorrect.
Thank you. So that's once again the correct and the incorrect answers. And I think, Joanna, indeed, what you already said, that option B can be very different according to the country that you're in. Okay, second question.
So question number 2 is on follow-up after discharge. So which of the following are correct? And once again, more than one answer is possible. So option A, follow-up endoscopy should be scheduled every week after discharge. Option B, every tracheostomy cannula should be disposed after every change since it can't be reused. Option C, though caretakers should be able to change a tracheostomy tube by themselves before discharge, they may need a hospital visit for assisted changes. Option D, cannula change should be performed every 6 months. And option E, when finding difficulties changing the tube, the stomal tract should be assessed in a hospital setting. So once again, we'll wait up for your answers. They'll have a pause shortly. Yes.
Yeah, there we go. Please put in your answers. Again, more than one answer is possible. We're at 65%, a little bit more. And we can close the poll. All right, I think I'll close the poll now, and we can share the results.
Okay, thank you so much for your answers. So all of you answered option E is correct, so it's completely true. Even though parents should be able to change by themselves the trach at home, whenever they find difficulties, parents should contact their team, their doctors or their nurses, and they should be helped during the cannula change in a hospital setting. And sometimes the problem may be with the stoma. There may be some problem with the skin. There may be a problem with the granuloma. And so whenever difficulties are faced, parents are urged to go to the hospital to have them the stoma assessed. So option E is completely correct. Most of you also answered option C as correct. Caretakers may need a hospital visit for assisted changes. Once again, when they leave the hospital, they should be able to do changes by themselves, but they are urged to do the first changes, the first couple of changes on the hospital. And so after that, as I said, there may be other reasons that should make the parents need help in the trach change. And whenever that happens, they should contact their team and they should have all the help needed. So thankfully, none of you answered option A is correct, because follow-up endoscopies should be scheduled depending on each child's case. So if they need to be scheduled every week, they should be, but if not, they should be scheduled as necessity determines. Option B, every cannula should be disposed after every change. That's not necessarily true. For some cannulas, such as Portex and Shiley cannulas, they should be disposed after every change. But there are the Vivona cannulas, for example, that they could be reused for 5 times. And so option B is obviously incorrect. Concerning option D, there is no consensus in performing cannula change, but most centers do say that changing cannula should be every month. So monthly changing of cannula is what's advocated in most centers. So option D is also incorrect. So options C and E are correct.
Thank you. Here it is again. In green, of course, the correct answers, and in red, the incorrect answers. Third question.
Well, the last question on my part concerning tracheostomy follow-up after discharge, which of the following are correct? So once again, more than one answer is possible. So option A, multidisciplinary follow-up tracheostomy program reduces adverse events. Option B, nursing community care is mandatory after discharge. Option C, in a multidisciplinary team, the speech and language therapist and physiotherapist role is interchangeable. Option D, though sometimes difficult to assemble, a multidisciplinary follow-up tracheostomy program reduces the hospital's financial burden. And option E, follow-up should be adjusted regarding the economic, social, and educational background of the parents and individual child's needs. So we'll wait for your answers.
Ring, ring, ring.
You answer. Every answer is able to be commented, so please answer.
Again, more than one answer is possible. I see that not everybody is able to answer. That's a shame, but hopefully that will sort it out in the next questions. Probably some technical issues. Okay, we'll close the poll and share the results.
Thank you so much for your answers. So most of you answered option A and E is correct. So option A on multidisciplinary follow-up programs, it's been proved that they do reduce adverse events. In a big 2019 study with 700 children, they actually reduced 43% of the adverse events at home. And so that's really a really good part for a multidisciplinary team to take. And also reducing adverse events also means reducing the number of hospital emergency room visits or normal consultation visits. And so it also reduces the financial burden. So both option A and option E are correct. Option D, I mean, are correct. Concerning option E, follow-up should be adjusted to every child and every family's backgrounds and needs. So even though we may have a program and every parent and every caretaker should have the program leaflet and everything, we do need to adapt it to every family's needs and every family's social background. That's really important because sometimes parents may not be able to do everything exactly the way we want them to, and we should work with their limitations. So option E is also correct. Concerning option B, that's also a tricky one. So nursing community care is something of a great, it's great, it's really useful, but not available in all countries. So in my hospital in Portugal, we do have a nursing community care, but only for the Lisbon area. And so sometimes it may be difficult to have nursing community care after discharge. So that should not be a necessity for discharging children. So option B is incorrect. Concerning option C, it would be ideal to have both a physiotherapist and a speech and language therapist in our team. Sometimes that is impossible, but they do have quite different roles. And thankfully, we do have Joanna with us that could actually explain better the different roles these two therapists have on teams.
Yes, absolutely. So I'm Jo Matthews. I'm a speech and language therapist, and certainly we work very closely with our respiratory physiotherapy colleagues. Our roles, I would say, are very complementary, but if you think of it that we each have our own specialities, so we each work within our own box of our speciality, and those boxes cross over at some parts. So there is a grey area between us where those roles may be more interchangeable with some aspects of patient care. But certainly we would actually want to have both of us working with the child with the tracheostomy, particularly with a child if they are ventilated as well. We often explain it to our parents that as a speech and language therapist, I would be responsible for the tracheostomy tube and upwards, and the respiratory physiotherapist would be responsible for the tracheostomy tube and downwards. And then there is, of course, that middle bit of the tracheostomy tube where we may come in together, and particularly around secretion management. That's where the respiratory physiotherapist might be involved above the level of that trachea tube as well. So yeah, I mean, I can go into more detail later on the different roles if that's helpful, but do you want me to say any more now, Joanna?
Perfect. That's quite a good division. Upwards from the tube and lower from the tube. That's really good. Thank you. Thank you so much. So option C would be incorrect. Yes.
Okay, so once again, here are the correct and incorrect answers. Thank you, Joanna and Jo, of course. Next questions will be handled by Kate and Jo again.
Thank you and welcome everybody. I hope you found the course material so far helpful, and that these questions now will just bring it all together, help consolidate what you've learnt. And I think particularly for this next section, so the next 3 questions I'll go through with you, these are to do with tracheostomy, or what are called speaking valves, a bit to do with swallowing and capping, which again will lead into the decannulation aspects as well. And this may be even more different from region to region, and it may be something that's not part of the very basic package of care that comes with a tracheostomy. I think we think of valves and things as, although we'd love for them to be standard of care for everybody, they may not be standard of care for every country and every region. So it'd be interesting to know your thoughts on this, and certainly if there are questions, I hope there are, let's put them in so we can all talk about them as a panel at the end. Okay, so question 4, please say which of the following answers are correct about tracheostomy or speaking valves. And again, more than one might be correct. So, do they prevent expiration? Do they prevent breathing out through the tube? Are they two-way valves? Are they the same as HMEs, otherwise known as heat and moisture exchangers? With valves, can they only be used over the age of 3? And is a Passy-Muir valve a bias open valve? Thank you.
So again, more than one answer possible. We were at 80%. We'll wait a little bit longer. All right. We'll share the results.
Okay, thank you everybody. So about the valves, Yes, they do prevent expiration through the tracheostomy tube. Okay, so rather than the air being exhaled through the tube, if the valve is closed when you're breathing out, the air will be directed up around the tube to the subglottis, to the vocal cords, so then it can work with a greater pressure to use for vocalization. So that's correct. That's how the principle of speaking valves work, that they prevent expiration through the tube. They close off just during the expiration, particularly in that phase. But they're not two-way valves, they're one-way valves. Okay, so the second part, part B, would be incorrect. Most people were correct that they're not the same as heat and moisture exchangers. Apart from that, they're both little attachments that go on the outside of a tracheostomy tube. They don't do the same thing at all. Okay, and the fourth part, part D, is a tricky one. Okay, they can be used under the age of 3. I think we'll talk hopefully a little bit later about the ages that everywhere thinks they should be used, but certainly there isn't a cutoff at age 3. They can be used younger. In fact, some manufacturers say they can be used even in the first few months of life. However, there are practical considerations, and that was touched upon in the educational material. Okay, so definitely can be used under the age of 3. Okay, and lastly, the part E, that is false, because a Passy-Muir valve is bias closed. Okay, so it tends to be closed rather than open in its resting state. Okay, so of all of those, just to recap, part A was the only correct one.
Thank you. Once again, there's the only correct answer, A. Question number 5.
Thank you. Okay, so which of the following are contraindications, meaning that you can't do it, for a tracheostomy valve trial? Okay, and again, more than one answer is possible. Okay, so firstly, if the child's asleep. B, if it's a cuffed tracheostomy tube and the cuff is inflated, the cuff is up. Part C is long-term ventilation, a contraindication. Part D, if the child's previously had a trial of a valve and that hasn't worked. Or part E, a grade 4 subglottic stenosis. See what you think.
Up to 74% now. Just wait another 10 seconds. And I'll share with you the results.
Okay, thank you everybody. So we wanted to pick up the contraindications, and most were correct with part A. Okay, a tracheostomy valve should never be used if the child's asleep. Okay, that's for regular use or for a trial. Okay, so A would be incorrect. Yeah. If the cuff is inflated around a tracheostomy tube, as in part B, then the child will not be able to breathe around the tube. The child will not be able to pass air up towards the subglottis. So it means when the valve is closed, they wouldn't actually be able to move air. Okay, so it's absolutely vital that if a cuff is up, a valve cannot be used. Okay, that's not to say that a child might have periods of time where the cuff is deflated, or that plan might be might change. They might end up with an uncuffed tube. So it must always be thought about, but certainly if the cuff is inflated, they can't use a valve. Okay. Long-term ventilation is an interesting one. Okay, 60% of you thought it was a contraindication to using a valve. And actually you can use a valve with long-term ventilation. Okay, obviously it has to be assessed, and that's why it says a trial rather than regular use. So you can certainly do a trial. There are valves that can be used with ventilated patients. There are specific types of valves, and it requires a lot of expertise to look at whether they can be used and the successes and what have you. But certainly just because a child's ventilated doesn't mean that they can't trial a speaking valve. Okay. Part D, everybody was pretty much correct there. Okay, so just because a child perhaps hasn't succeeded in a trial of using a valve before doesn't mean that something hasn't changed. You know, the age of the child, the neurological status, the size of the tracheostomy tube, all of those things matter, and we'd really want to know, well, why weren't they successful? You know, it's often not black and white as in success and failure. So we'd need a lot more detail about the process that they went through for the valve assessment before knowing whether it's likely to be sensible to try again. Okay, and I think it's something that we must always keep in mind, as I said. Okay, the last one, part E, should be pretty clear, because a grade 4 subglottic stenosis means that there is no airway, there's no lumen at all, okay? So that means that the child doesn't have an upper airway to breathe through or to vocalize with. So if there is a completely closed upper airway that's not patent at all, you couldn't use a valve. So of those, if we go back to the colors on the slide, so we've got a few that are right and a few that are wrong. Okay, and my last question with you this evening, question 6. Please identify which of the following are correct when thinking about swallowing and feeding with a child that has a tracheostomy. Can be more than one answer. Part A, children with a tracheostomy can never swallow normally. B, does tracheostomy valve use decrease subglottic air pressure? C, videofluoroscopy should never be performed in children that have a tracheostomy. D, a tracheostomy affects motor but not sensory skills. And lastly, E, can a cuffed tracheostomy tube, an inflated cuffed tracheostomy tube, affect swallowing more than an uncuffed tube?
Just wait 10 more seconds. We're about 80% now. People who voted, please get your votes in. Or votes or your answers, sorry. All right.
Okay, so we've got some mixed stances here, but you know, I thought the questions, they shouldn't be too easy for you to get you thinking. Okay, I think we've got some good answers here. Okay, so children with a tracheostomy, although a tracheostomy can affect swallowing, it doesn't necessarily. So certainly children that have a tracheostomy, they might be able to swallow normally. It obviously depends on their comorbidities, their neurological function and what have you. But certainly we should always assume that they should be able to swallow and think about assessing that swallow. So certainly Almost everybody was correct on that one. Now, in terms of subglottic air pressure, okay, when you use a valve, so the valve is closing on expiration and it's redirecting air up through the subglottis, it'll actually increase the air pressure. So most of you were correct on that one, because tracheostomy valve use increases the air pressure rather than decreases it. Okay. Thinking about a video fluoroscopy, you know, a swallowing assessment using radiology. It certainly can be performed in children that have a tracheostomy, so most of you were correct there, and it can be a very useful form of assessment for them when thinking about swallowing evaluation. Okay. And the effects of a tracheostomy on swallowing and feeding, they're really, really broad. There can be lots of different effects. So it can affect motor skills, okay? It can affect how not just the muscles work around the different air pressures, if you like, but also the movement of the larynx might be altered when it needs to elevate and move forward for swallowing. So it can affect motor skills, and it can also affect sensation as well, thinking about feeling the movement of air through the normal swallow, thinking about the sensations of secretions as well. So it affects both of them, so that one will be incorrect. Okay, and the last one is a tricky one, but I'm pleased that most of you got it right, okay, because cuffed tubes can affect swallowing more than uncuffed tubes, okay, and again, that may be for both the motor and the sensory side of things, so well done.
Okay, so here again are the correct and incorrect answers. Kate, did you want to discuss the handout as well?
Yeah, so I hope all of you can see within the webinar, there's one handout, okay? And this is a chart that we've created at my hospital and Joanna Matthews Hospital. And we use this for lots of different things when considering when we're placing a tracheostomy tube, what might be the age appropriate tube for the child, but also when thinking about taking a tube bigger or smaller. What we call upsizing or downsizing. And I hope you can see, and you can download the handout, feel free, or put it onto your device. You can see the common types of tracheostomy tubes. You know, at the top there, the Shiley and Bivona tubes. We've also gone into some of the rarer types of tubes at the bottom. But from the top to the bottom, it looks at the age of the child and then gives you the dimensions, the outer and the inner dimensions of all of the tubes. And we've got to think about not just the inner diameter of the tube, but the outer diameter of the tube is really important. It's how much space this tube takes up within the trachea. And that space is really important when we're thinking about a valve. If you've got a small child, say a child who's only 9 months old, who's got a size 3.5 tracheostomy tube, there'll probably be very little space for them to breathe around that tube, either to use to get a voice just through a leaking of air, a leak voice, or if we were to put a valve on, they might really struggle because they haven't got the space to breathe around that tube. So you can use this table to think about what the tube size options are, or if you think, okay, well, if I go a size smaller, what will be the actual differences in terms of the size of the tube, and what can we expect? And certainly if you have to change between different manufacturers of tube, thinking about different needs for a cuffed versus an uncuffed tube, again, that's really important, and that's just thinking about the diameter. Again, what I find really useful with this is it's got the length of the tube as well. So when you're thinking of changing from a neonatal to a pediatric tube, this gives you exactly how much longer that tube might be on the inside. A really important factor when you're thinking about accidental decannulation, or if a tube is too long, then it will get towards the carina, as we talked about in the last session. So if you want to, have a look at this chart, and I hope you'll find it useful.
Thanks. It looks really, really helpful. Joe, was there anything you wanted to add on the tracheostomy, the influence of tracheostomy on swallowing function?
I could probably talk for the entirety of the session on the impact or potential impact of tracheostomy on swallowing. It's whether, is it for questions later, do you think? I've got lots of things I could say. on exactly how it impacts. It's whether you want me to wait till later really and see what people want to ask.
I think that will be a good idea. We'll get back to that later. Fine. Yeah. Thank you. Next session is for me. That was on decannulation protocols, which is also a topic, I think, which has a large variation between countries and between hospitals. So we try to make it as agreeable for everybody as possible, but of course there's bound to be some discussion, so we're definitely open for that. So question 7 is concerning decannulation protocols. Which of the following are correct? Again, more than one answer is possible. Is it A, there is an international consensus on the best protocol? B, they aim to improve the safety and success rate of decannulation? C, they usually involve a capped sleep study? D, after decannulation, careful monitoring is mandatory? And or C, if the trach cannot be capped, decannulation is not possible. So I will start the poll. Oops. There we go. Awaiting your answers. Okay, I think everybody put their votes in. So let me share the results. Question A, there is an international consensus on the best protocol. That is untrue. Unfortunately, there is no international consensus. There is a paper in the making of the IPOC group, which will probably show what most centers do, but there is no one international best practice on decannulation protocols. So that's also, of course, the reason why you can debate them so much. I think we can all agree that the aim of decannulation protocols is to improve the safety and success rate of decannulation. They do usually involve a capped sleep study, not always, but usually they do, and in most centers they do a capped sleep study, and capped meaning that the tracheostomy is sealed off and the child goes to sleep in the hospital with some sort of measurement. Also, and most of you got this correct, is that after decannulation, careful monitoring is mandatory. You don't decannulate a child and send them home right away. Usually they stay in the hospital for close monitoring for a number of days. And E is a little bit of a tricky one. If the trach cannot be capped, decannulation is not possible. That is usually the case, but not always. If you have a very small child, and if you remember the trach chart that Kate showed you just a couple of minutes ago, then you can acknowledge that if you have a baby with a tracheostomy 3.0 or 3.5, then if you look at the outer diameter of the trach tube, then you can understand why that baby can probably not cap their cannula, but you can probably still decannulate it if the problem is solved that needed the trach. So usually if you cannot cap the trach, then you cannot decannulate, but there are some exceptions, and especially very small children probably will not tolerate capping their trach, but could possibly still be decannulated. Okay. There we go. Once again, correct and incorrect answers. Question 8. Again, more than one answer is possible. Before decannulation, A recent airway assessment is advised. B, a recent swallowing investigation is required. C, daytime capping trials have to be done in the hospital. D, downsizing before capping trials or a sleep study is a bad idea. Or E, the child has to be at least 1 year old. So I will start the poll and await your answers. Okay, and I'll share the results. So, before decannulation, a recent airway assessment is advised. All of you got that correct. Congratulations, that is true. It's always wise to have a recent airway endoscopy whenever you think about decannulation. You can assess the airway, check for feasibility of decannulation. You can check for supraglottic granulomas, which Georgios will talk about later, and try to even improve the airway so the chances of decannulation are increased. Before decannulation, a recent swallowing investigation is required. Joe, maybe you can elaborate on it. What do you think?
Well, it's an interesting one. We come up against this quite often, really. So a child doesn't tend to be given a trachea because they've got a poor swallow. We've got lots of children with poor swallows and safe swallows that don't have a tracheostomy. But it does become more of a problem if the child has an unsafe swallow and they already have a tracheostomy, because that tracheostomy is considered a support for managing that chest and keeping the chest well. So it's an interesting one, actually. We have a few cases at the moment that we're discussing. What should we be doing around decannulation when they've got an unsafe swallow?
Yeah. Same here. We tend to like to have some sort of swallowing evaluation before decannulation to just know about the swallowing. If there's no problem with swallowing whatsoever, then there's no issue, of course. But if there are swallowing issues, you just want to try to get an idea of what decannulation will do for that swallowing. Will that improve it, or will just make the child still aspirate, and then you won't be able to suction anymore?
Absolutely.
So daytime capping trials have to be done in the hospital. Half of you said that was correct. Well, that answer is incorrect. The capping trials daytime can be done at home. First time capping, I would advise to either do in the hospital or do with a specialized nurse to assess whether it's feasible. But after that, we have a schedule that you do it for 1 hour, then 2 hours, then 4 hours. As long as it's daytime and the parents are there, then they don't have to do it in the hospital. They can do it at home. Downsizing before capping trial or sleep study is a bad idea. No, I think almost all of you got that wrong. Right. Downsizing is a very good idea. It will probably increase the chances of success of decannulation. And the child, of course, does not have to be at least 1 year old before decannulation. All of you got that correct. So once again, A and B are correct. Then after decannulation, again, more than one answer is possible. A, the child is sent home immediately. B, the necessity for CPAP indicates a failed decannulation. C, the tracheostomy can close very rapidly, making reinsertion of the tube difficult. D, patients are advised to start swimming lessons immediately. Or E, close follow-up after discharge home is required. Start the poll. Okay, and I'll share with you the results. So all of you got A correct. That is, of course, not correct. The answer is not correct. The child is not sent home immediately, but has to stay under strict surveillance for 24, 48 hours or whatever protocol your hospital has. B is a tricky one. Most of you had that correct. The necessity for CPAP after decannulation does not per se indicate a failed decannulation. It could be used as bridging for some airway problems that you think will resolve over time, or could aid in children who need CPAP for OSA or other type of sleep-induced problems. C is correct. Most of you had that answer correct as well. And this can be very tricky in small children. The tracheostomy can close very rapidly within hours after decannulating. And it can be very difficult to reinsert the cannula. So that's one of the reasons why you want to be absolutely certain that the decannulation will not cause any major problems. D, of course, is not correct. Strangely, that is a question you often get. After the cannula is out, at least we do in the Netherlands, maybe because everybody likes swimming so much or we have so much water. Patients are, of course, not advised to start swimming lessons immediately. They can only start swimming lessons as soon as the stoma is completely sealed. And E was correct. Most of you answered that correctly. Close follow-up after discharge home is also required. So once again, those are the correct answers. And now for the last part, we move over to Georgios.
All right, good evening everybody from Stockholm. My part deals with, I would say, late complications to tracheostomy. And one of the things you might end with after decannulating a child is persistent fistula. And since you have both air and secretion leakage through the fistula, it has several disadvantages. But one of the options below now is not true regarding a persistent fistula. And the options are inability to swim, poor cough, difficulty in swallowing, skin irritation, or weak voice. So I would ask Bas to start the poll, please.
Yeah, it's up. 10 more seconds. We're about 80% of the people who have answered. Okay. And here are the results.
Okay. Well, since you have an opening located in the neck, as Bas mentioned, I mean, you cannot swim until the fistula is closed. So having a fistula gives you an inability to swim. So option A is not correct. Option B is also not correct because having a fistula leads to air leakage through the fistula, meaning that you cannot build up enough pressure to have a strong cough. So option B is not wrong, not right. Option C, on the other hand, although several children with tracheostomy have difficulties in swallowing, having a tracheocutaneous fistula is not associated with difficulty per se. So the fistula does not give you any difficulty by itself. So the correct answer is C. And skin irritation is a disadvantage you have when you have a lot of secretion coming out of the fistula. So that is wrong also. And weak voice is also a disadvantage, having an air leakage through the fistula. So the only option that was right was option C. Okay.
There you have it. Okay.
Moving on to the next question. It's regarding suprastomal granulomas that are actually quite common in tracheostomy children, both stomal granulomas and in the trachea, where they're called suprastomal granulomas. So the question is, which of the following are true regarding granulomas? Can they cause bleeding? Can they result in inability to phonate? Do they usually develop rapidly within hours? Can they make a tracheostomy tube change difficult in any way? And the last option is, do they usually require open surgery when they are, there is a need to remove them? And more than one answer is possible.
Okay, I think everybody put their votes in. And these are the results.
I'm happy to see most of you got it right, because option A is correct. Granulomas are well vascularized tissue, and they may cause bleeding, of course. And if you have a large suprastomal granuloma, it blocks partially or completely the airway, or I would say the airflow up to the vocal cords, and that may result in either a weak voice or also in inability to phonate. So option B is also correct. Happy to see that most of you got it right. And granulomas do develop rapidly, but not within hours. They usually need days or weeks to develop. So option C is not correct. Option D is also correct because if you have a large suprastomal granuloma, it may interact with the airway and the stoma canal and make a tracheostomy tube change tricky or sometimes even very difficult. So option D is right, but the last option is not correct because most of the suprastomal granulomas, if they do need removal, you can do it either through the stoma itself from the outside or endoscopically through the trachea using either an optic and forceps or a bronchoscope. So the correct answers are A, B, and D.
Thank you. I have a video here. Georgios, I will play it. I hope it runs. I think
Just
so.
to give you an idea of, this is a really large suprastomal granuloma that actually is completely blocking the airway, and you can easily understand why you might have difficulty in phonating and also bleeding problems. And if they are really long, they can go down to the area of the stoma. This is now after the granuloma removal. You can actually see now the area where the stoma is, and now you have the cannula inserted with some small bleeding after the removal, which has been done endoscopically.
Very nice. Oh, yeah, there we go.
And the last question is regarding a late complication after removal of the tracheostomy. The normal trachea has the shape of upside down U, and if you have what we call an A-frame deformity, you have a weakening in the tracheal wall resulting in a collapse. Let's see, there is my camera. This is the normal cross-section of the trachea. You have a weakening of the anterior wall, and you get with what we call an A-frame deformity. And the question is, where is this deformity located? Is it at the level of the vocal cords, in the subglottis, at the level of the tracheostoma, just above the carina, or at the level of the main bronchi? One option is correct.
Yeah.
I think this should be the easiest question of the poll. Let's see.
You never know. We'll wait 10 more seconds for the last people to answer. All right, there we go.
Okay. Well, as I said, only one option that is correct, and actually it's option C, because the deformity is developed at the place of the tracheostoma, because that's where the area is the cartilage is deformed. So instead of an upside down U, you get a deformity that is formed like an A. And I think, could we perhaps show the video I have, Bas? I think it quite nicely illustrates both the level and how it looks like. So this is a patient that has been tracheostomized. This is the area where we had the tracheostoma. This is the normal trachea below the level of the stoma, and here you see the classical A-frame deformity that sometimes might even be much more severe than this one, since you might have also a dynamic compression or movement of the tracheal walls that might sometimes even completely block the airway during inspiration or coughing.
Very illustrative. Thank you. So once again, this was the only correct answer. So those were the questions. I think it's time to handle some questions from the attendees. Let's see if I can do that. Yes. So I have a question here regarding stomal granulomas. I have additional questions, so I guess this is for you, Georgios.
Okay.
What do you use for treatment of stomal granulation tissues on the outside of the stoma? That's question one, I think.
Well, it's a good question because it's a quite common problem, and stomal granulomas, it's very important to keep the stoma open and clean, because having a granuloma at the level of the stoma might give you problems if you have an accidental cannulation. It might be difficult to put the tracheostoma back again. So very important, of course, to have the daily cleaning procedures. And if you develop a stomal granuloma, what at least in our place we usually do is to cauterize them with silver nitrate sticks that react with the granuloma and giving a protein denaturation that makes the granuloma shrink. And since I also mentioned that granulomas do develop quite rapidly, not within hours, but within days or weeks, that means that the sensory sensation is not really developed. So the granulomas are easy to remove most of the time without any pain, actually. But what we usually do is still to put some lidocaine gel before doing the manipulation.
Okay, and then a follow-up question on that is
one more comment. I would say you should be careful if you have granulomas inside the stomal canal to use silver nitrate, because then you might end with some silver nitrate going down into the airway and causing damage. So there it might be more advisable to use bipolar diathermia.
Okay, and then a follow-up question on granulomas, about which instruments do you use when you approach a suprastomal granuloma with a bronchoscope, and do you regularly perform checkup endoscopies to check for granulomas, or only on indication?
In my department, we usually perform regular airway checkups for children that are tracheostomized, but the indication is, of course, not just to check for suprastomal granulomas, but that's one of the things we want to have to examine. And removing a suprastomal granuloma is most of the time is quite easy. We use endoscopic view with a rigid endoscope into the trachea, giving you a good view on the screen, and then we just put in usually small sinus forceps, preferably angled, and you can on the screen see that you get a good grip of the granuloma, and you just pull it out. They are not strongly attached, so they're quite easy to remove. If you have difficulty in accessing them, you can of course either take them through the bronchoscope or use either a bronchoscope or an intubation tube to give you a bit more pressure from the inside, so you still can get them from the outside. It's much more easy to remove them through the stoma rather than through the bronchoscope.
Yeah.
And you should always be there prepared to deal with the bleeding that usually comes afterwards. So you should always have some small pieces of, I'm not sure the name of it, the neurosurgical small pieces that we use, soaked adrenaline. You can just put them on the area.
Yeah, and you have to use the one with the wires, right?
Yeah, exactly.
With the threads on it.
You should not lose them into the airway and have an exciting foreign body.
Okay, one more question again for you, Georgios. What do you do for suprastomal collapse? Also with large granulomas, but I think the collapse can also be a big problem.
Yeah. Do you have the pictures? Could we have the picture with the collapse? I think I had a couple of pictures on the material they had, and we can discuss the question related to that. Is it easy? Is it easy, or should we just take it in theory?
I'm looking.
I mean,
easy. Yes, I think I have it. You're looking at my screen now, correct?
It's the one with the 3 pictures. There it is. Yeah. So suprastomal collapse, you always end up with some form of collapse when you have a tracheostomy tube inserted in the trachea, because you have a pressure from the cannula. So what you see in picture A is always, I would say, normal. It's when you have what you see in the middle picture or at the last picture that you have a severe collapse. That, of course, is going to give you problems when you decannulate a child. Although removing the cannula usually gives you a bit more space, but if it looks like in the last picture, it's not going to end up well. You need to do some kind of surgery to lift the anterior wall, and that, of course, it's difficult to give just one option. What usually is enough is to at least what we usually do is to create a swing door. Do you see my mouse here, or is it just me that?
No, I don't see your mouse on my screen.
You don't have to. What we usually do is to create a swing door, and by that putting some stitches onto the anterior wall and try to pull it out from the airway. Usually that is enough, but if you have a really severe collapse, you might end needing to put in also cartilage graft to deal with that problem locally. That's not really the common case. Most cases you can deal with local flaps and, as I said, swing doors.
Okay. Yes, I think those are the questions from the attendees. And then, Joe, maybe we can shortly get into the influence of the tracheostomy tube on swallowing. Do you think you can?
Yeah, definitely.
Explain
I was hoping you'd come back.
Us simple ENT surgeons in a way that we can understand. It's really difficult stuff.
Do you know, I have worked in dysphagia, so swallowing problems, for about 17 years. I was trying to work out. So I trained in adult dysphagia and then moved across to pediatric dysphagia, and I am still learning. So it is a really complex process. But trying to put this simply in terms of the world of tracheostomy, basically by giving a tracheostomy, we're opening up a system that should be closed. And the reason that we want it to be closed is because things like swallowing rely on pressures and and rely on that system being closed to be effective and work as well as they can. So by giving the tracheostomy, we're actually having an impact on the actual function of that swallow. Just considering subglottic pressure, so we spoke about that. Now, if you actually Google subglottic pressure and swallowing, you could read for years, I think. There is a lot of evidence out there on the role of the subglottic pressure on the actual function and airway protection. By giving a tracheostomy, we have reduced that subglottic pressure, and therefore the functioning of the airway in protection during swallowing is going to be impacted on. So that the upward forward movement, the closure of the airway at the vocal cords, the false vocal cords, the epiglottic coming over the top, all of that may well be impaired just by pressure. So your motor functioning. Just also considering though the protective function of expiration in swallowing. So probably lots of us have not really thought that when we swallow, we breathe out after. And part of that function is that if anything's hanging around at the top of that airway, that pressure of breathing out will actually push it away from the top of the airway. And then we will perceive and feel and sense that it's there, and we can do a secondary swallow. But by having a tracheostomy, we're no longer breathing out through that upper airway after swallowing. And also we've reduced the sensation. So actually people may not be able to feel and be aware that there's anything in that upper airway or above that airway that they need to re-swallow. So sometimes that secondary clearing swallow can be impaired by having a tracheostomy, even if the primary initiation of a swallow, which is the brain's functioning, even if that's happening, there are elements of the swallow that may well be impacted on. And just not to forget as well that swallowing and feeding is not just about the structures and the functions and what happens physiologically, but actually it's to do with motivation to eat as well and a will to eat. And some of that comes with taste and smell. And by having a tracheostomy, your ability to taste and smell is going to be impaired. And you know yourselves, if you've got a heavy cold, if you're trying to eat and it just doesn't taste of anything, you're not really that motivated. So then thinking of some of our little children that may have started life with NG tubes and their oral feeding opportunities and experiences early on have already been impaired, to then also not really have very much to motivate them to eat in terms of taste, may make that journey even harder. So three main bits really. So the functioning of the swallow, the sensation and the awareness, and then actually that taste and smell and motivation. I told you I could go on forever.
Yeah, it's really fascinating. I've seen like amazingly positive effects on simple things like speech valves on children who were aspirating and then suddenly swallowed normally. It's just, it's impressive sometimes.
I can't believe I actually forgot to mention valves when talking about swallowing. That's all I seem to talk about, isn't it, Kate? So actually the use of the tracheostomy valve, I mean, I just say every child with a tracheostomy should have a tracheostomy valve plan. That doesn't necessarily mean they can tolerate the valve. It doesn't necessarily mean we're at the point of being able to put that valve on, but it should be considered at the point they are given that trachea. So we are monitoring that, and as soon as it becomes appropriate for that valve to be in place, then we should be using the valves. And I could go on forever about the benefits of valves again. That's probably another question, is it?
I'm stopping you there. Yeah. Thank you very much. Joanna, I had a question for you as well. You said rightfully so that you should tailor your follow-up plan according to the income and the social background of families. So do you have like an advice for people who have children with tracheostomy with low income situations, with difficult situations on getting into the hospital? Is there what will be your advice on following them up?
At the times when a multidisciplinary team is really important. So, and our hospital, even though it is like the tertiary hospital in Lisbon, we still have children that live very far away from our city. And so we should have the work of social workers and the nurses, and all of them should work together to have and find a financial means to have the children come sometimes, because they sometimes need to definitely come and have surgical procedures. Sometimes that's even hard to manage. We have to find places for parents to stay and grant them those places to stay and make them feel secure with us. So it's actually also a trusting relationship with families. Most of the times, those families also seem part of our own families, because those are the ones that are really tricky to deal with. So we do have plans, but we have to discuss them all the time with parents. And finding the funds sometimes is hard. So we rely on the hospital and on the public service, National Public Health Service, to help us on that. But sometimes it's really hard. We do also try to communicate with the local primary centers, but sometimes that's hard. And so most of the times, children just have to come to the hospital whenever they're in need. It's hard to determine a plan. It's really tailored for each individual case. Yeah.
Okay, thank you. Well, if there are no more other questions, maybe some questions from the other panelists or Vincent.
Yes, Georgios, I wanted you to specify something about the A-shape deformity. Is it frequent? And then how do you address these A-shaped deformities after trachs?
I think it's much more, or at least I see it much more frequently in adults, not so much in children. Of course, dealing it depends on how severe this A-frame deformity is. The severe ones you really need to address with usually what we have to do is some kind of tracheal surgery, meaning either a tracheal resection, or if it's more moderate, you can do some endoscopic surgery, meaning that you can remove a part of the cartilage that is pressed inwards. The difficult ones are, I think, the ones that you have not just a rigid deformity, but as I mentioned, the ones that have a more dynamic form, meaning that they have a really soft cartilage that you really have to address, and that usually ends up with a resection, either regular resection or which I think might be more advisable, a slide, so you can keep a part of the affected area, and you also get a larger anastomotic area with sutures, giving it stronger post-op period.
Okay.
Anybody doing anything different?
Kate,
No, thank you, Georgios. And I think I agree completely. This is not something that we tend to see in pediatric ENT, and that's a good thing because it's difficult to deal with. I think it can be more associated when cartilage is taken away in a window when doing the tracheostomy, or a Bjork flap is done, which tend not to be the techniques in children. Yeah. But I think, as you say, there's no one answer, and I think the preoperative assessment is so very important, whether it's a static or a dynamic collapse, because if you've got a good airway lumen, does it matter that it's not round but it's triangular? Of course, your airflow dynamics will be slightly different, but not every A-frame deformity has to be operated upon. No. It may be a feature of their airway that can stay but be known about and monitored. But of course, when it has a big impact and looking at all the levels in combination, then you're into the surgical options, as you very well said.
Can I ask another question, maybe to the panelists? Do you systematically do an endoscopy after decannulation, and when?
I'll go first. We don't do systematically endoscopy, only on indication. So when the child's not doing well or is more stridulous or is having difficulty, which you don't expect, or you think there's something we can fix, then we will do the endoscopy. But if the child's doing fine, then we would not schedule any OR. No.
Okay, what about the other panelists? Same attitude, I guess?
Yes, very similar. It wouldn't be automatically another endoscopy. However, if there is a persistent tracheocutaneous fistula, we would usually give that at least 6 months to close on its own. So not rush into closing it, not rush into a repeat endoscopy unless the child was unstable. But when there is a persistent fistula, you have to think, is there a reason it's staying there? Is it because the upper airway isn't adequate? So before closing the fistula, we would always do an endoscopy either immediately before or within the 6 weeks before.
Okay. There is maybe another situation when you have people coming from abroad and they have to come back home quite quickly. It's also sometimes safer to do an endoscopy if you want them to come back to their home country.
Yeah, that's true. If they have to travel for a longer period, then it will be very safe to assess the airway. Yeah.
Any other questions?
No, I think we have a lot in common. Yes, I think with our frequency of surveillance, the monitoring endoscopies in a child that has a tracheostomy, I would say, it's between every 6 and 12 months. If a child is very prone to getting the suprastromal granulomas, if I see one, I'll probably look again at 6 months rather than leaving it a whole year. But obviously, we don't want these children to have a tracheostomy any longer than they need it. So you're being proactive, trying to give them as normal function as possible. And as Joe said, with the having a valve, that will help them in every way with the speech, the swallowing, the upper airway dynamics. And I think it's my belief and my observation that they will have better laryngeal function, better laryngeal tone, and better laryngeal habits if they've been using a valve. So when you're thinking about planning any upper airway reconstruction to decannulate, if they're supported by a valve, if they can use one, they really should, because it will be very, very helpful.
And I think also valve, sorry. I think valve might also prevent formation of granulomas. Airflow is really good for the inside of the trachea.
Okay. We were going to say the same thing anyway. And I also was just going to add that we tend to link very closely with our ENT team anyway. And because we're using valves with so many more of our children, sometimes that can indicate when they maybe need a scope, when someone needs to have another look, because they may be using a valve perfectly well and then suddenly something changes and they're working a little bit harder. So they'll come in, I do a SLT-led trachea clinic, so they'll come into my clinic and we can assess that and try to work out what's going on and whether we think that they need to go and have a further investigation. So sometimes the use of a valve can actually support the timing of those other interventions and scopes.
I was about to say that the decannulation process with us also starts. It's really important to know that a child can tolerate their valve. And so for us, that's really important. That not all children are able to have a valve, unfortunately. But the children that we think that may tolerate decannulation, those are the ones we really invest on having a valve first. So for us, that's really the first step of the process, actually.
Absolutely.
I think we all agree. Okay, so if there's no more questions, I'd like to thank you all. Thank you all for your hard work, and thank you for being here tonight and joining us. Thank you for all the attendees for joining us. And I think that's it. So we'll just wrap it up. Good evening, everybody.
Good evening. Thank you.
Bye, everybody.
Bye.
Thanks.